Kia ora koutou. Um, Welcome to our Hospice West Auckland webinar today, and thank you very much for joining. And thank you to the team supporting me today. Just a few housekeeping things before we begin. As you've seen from the welcome screen, checking audio, make sure you can hear me and see the screen. Please use the question and answer Q&A function for any questions for myself or the panel, and for any thing that is not content related, please use the chat function. And note we are being recorded today. And again, thanks for joining. I'm now going to share my screen. And I hope you can see my presentation now. So yes, today we're going to be talking about palliative care in the context of renal failure. And before I get into that, start with a karakia, accompanied a beautiful picture of one of our West Coast beaches, Piha. Kia tau te manaakitanga, ki runga, ki tēnā o tātou. Kia piki te ora, kia piki te māra makatanga. Kia hoki pai atu, kia hoki pai mai. Tūturu whakamaua, kia tīna, tīna, haumie, huie, tāike. Thank you. And a bit of introduction for myself. I'm James. I'm a doctor here with a registrar training in palliative care, and currently seconded with Hospice West Auckland while I complete my advanced training in the Waitemata region. And yeah, really thankful for the opportunity to talk today about renal failure and the context palliative care's role. To start with, just to recap about how our kidneys work and the role they have in our body, some definitions about context about renal failure, then common symptoms, then the why, when, and how of palliative care, and then we'll case and a panel discussion with before question and answers. It's quite a lot to cover, so I'll whip through. Yeah, so what do our kidneys do in our body? I think of them as our filtering organ, and that's to control our body's water balance or fluid levels, as well as salt levels, and not just sodium, but potassium, calcium, phosphate, and lots of other small minerals. It's easy to forget that they also have, our kidneys also have a hormonal role, particularly vitamin D to support bone structure, erythropoietin to help our blood formation, and then lastly and most importantly is metabolic end products and removal of toxins, acids, and particularly urea, which is common for a common culprit of symptoms in advanced stages of kidney disease. I like to think of a metaphor for kidney function as keeping our swimming pool clean. The filter for our pool keeps the water at the right level, keeps the water nice and clean, and a pleasant place to swim or live in. If our kidneys start to fail, grime builds up, the water level might be erratic, and yeah, things just slowly go awry often without a clear source of why things are feeling not quite right. And so if you keep that model in mind throughout, it can be a useful way to think of where the symptoms are coming from and how we might control them. Particularly now for renal failure, it's synonymous often with chronic kidney disease, and chronic kidney disease being a persistent or greater than 3 months drop in a kidney function below the normal level, usually defined as 90 mils per minute And that's where our terms such as creatinine clearance or estimated glomerular filtration rate, EGFR, gets quoted by physicians. We think of end-stage renal failure as the most advanced stage of chronic kidney disease, CKD5, EGFR, or less than 15 mils per minute. Remembering major causes, particularly in New Zealand, is diabetes and hypertension as a cause of kidney disease, and often kidney disease can result in these disorders also. Knowing that if we're thinking of our body in this swimming pool that our kidneys are controlling, if our organs are in this dirty pool, we will have the other those organs will be starting to struggle. So there's a lot of comorbid organ dysfunction in kidney disease. We have some polls today, so for some interaction. You'll see a poll pop up, and the question today is, what stage of chronic kidney disease do symptoms tend to occur? And these are symptoms caused by chronic kidney disease. Is it 1, an EGFR of greater than 90, CKD2, mild, EGFR 60 to 89, CKD3, 3A, 3B, 4, or 5? Give a few seconds, minute or so for that to happen. We should have some results pop up. Perfect. That's great. So the majority of us have said, yeah, symptoms start around level 3, 3A or 3B, and a few more, 4 and 5. I think that's pretty well right. And certainly we know that medications are our renal filtering capabilities start to worsen at CKD3 and below, and that's when medication adjustments are required. And then, well, the textbooks tend to say that specific symptoms attributable to kidney disease alone occur at CKD level 4 or 5. And that's what we'll be focused on today, is CKD, CKD4 or 5, and that's kidney function at approximately a third of the normal level. It's important to remember always with the thing about kidney disease compared to other chronic organ dysfunction is that there is an excellent treatment available that can replace kidney function, and it's renal replacement therapy. And whether that's a renal transplant, receiving a new well-functioning kidney, or whether that's dialysis, and that being blood dialysis 3 times a week for 4 hours or so, hooked to a machine, or peritoneal dialysis, where fluid is placed in our abdomen to do the filtering, often overnight, or it can be persistent through the day. There is also a significant need for medications to replace the hormones and manage salt balances in other ways, and that's the renal supportive care throughout all of these modalities. The hope is for a perfectly pristine pool, though we know if we're only filtering so often that these can be varying degrees of effect. And that's where challenges start to arise. We know that renal failure has a wide array of symptoms, knowing its wide varying roles. It result is often associated with many comorbidities, particularly diabetes, heart failure, and vascular disease. There's heavy healthcare utilization, and this Australasian cohort study found that around a quarter of people will be with chronic kidney disease will have 6 acute hospital admissions in their last year of life, regardless of any stage of CKD from stage 3 to stage 5. Therapeutic options become complex because the kidney's major role in medication metabolism, and with the increasing prevalence of diabetes and hypertension, CKD is only increasing also. Recent um, surveys of or studies in South Auckland and Southland of New Zealand show that 1 in 10 New Zealanders have CKD, um, and then 1 in 50 have CKD5. So that the other major challenge here is with the symptoms is how prevalent they are. When a person has multiple, they're creating such a burden. The symptoms can arise from multiple causes, and the symptoms often interact and compound. And as I'll talk about, itch, restless leg syndrome, pain that can result in sleeplessness, fatigue, uh, also depression or cognitive impairments or poor concentration. So, how common are the symptoms of advanced renal disease? CKD5 patients in this survey reported over three-quarters had itch and poor energy. Around half had pain, muscle cramps, restless legs, and a whole other range of symptoms there at a high level. Some of these are not so common in other chronic diseases and require some special attention to make sure that they are checked for. And that might be something good that the renal team does all the time. But however, for us in primary or palliative care, we need to maybe more actively thinking about those. So I'll talk through some of the symptoms now. Pruritus or itch. In advanced or end-stage renal failure, it's the urea buildup or this loss of metabolic end products, buildup of metabolic end products that results in free nerve endings being activated. And the signaling is along those the same fibers as carry pain. Minimally histamine responsive, though sometimes they can be. Itch overall is very difficult to cure, but we need to reassure our patients always that they can be improved. And we know that reducing or improving itch symptom can improve quality of life. The treatment, we check with our renal team, is the dialysis adequate? Can anything be adjusted to help optimize filtration? Temperature can activate these nerve endings, and so we should avoid temperature extremes. And then it's not an error, emollient, emollient, emollient. Keeping the skin moist, and that is the mainstay of treatment. Some might not so much evidence in the literature, however, patients can report that capsaicin and particularly menthol added to our cream can be very effective. Similarly, then moving on to medications, which are often required, and gabapentinoids have the most evidence. Remembering that we need to adjust our dosing to account for kidney clearance being reduced. We would start with gabapentin or pregabalin at the lowest doses available, and giving them, if a person's on dialysis, immediately after dialysis, or if they're on conservative care, having gabapentin alternate days. That's to start with. Can increase up to a maximum of 300 milligrams once a day for gabapentin, or 75 milligrams once a day for pregabalin. Other treatments that are available have had varying success. Evening primrose oil, supplement, UV therapy, which may be, if available, great, and limited downsides, knowing that that's not a systemic therapy. And the antidepressant sertraline has also been shown to have some effect. Moving on to pain, we saw that that's common among end-stage renal failure, can come from multiple causes, often could be due to the cause of kidney disease, either polycystic kidneys or a side effect of poor kidney function of renal bone disease. The person has just widespread myalgias and aches and unable to mobilize. The renal team could maybe be able to guide treatment. However, there can be treatment related pain, cramps if someone's on hemodialysis, abdominal pain if they're due to the fluid shifts in their abdomen when they're having peritoneal dialysis. And we know that the prevalence of CKD, that people are also going to have other comorbidities, osteoarthritis, vascular disease, diabetic neuropathies. Patients also have cancer, so they may have cancer-related pain. The big issue in kidney disease is making sure or adjusting our medications and avoiding things that are going to make the situation worse. And I've put in particular, when it comes to pain medications, that non-steroidals need to be avoided or have very close consideration, and opiates need some adjustment. I find that searching through the New Zealand Formulary or the St George's Renal Handbook, which can be Googled as from St George's College London, has excellent sources of adjusting or finding out what renal metabolism is for each medication, and a good way to help guide me if I need to adjust if I'm thinking about therapeutic options for someone with advanced renal disease. Generally, for pain, and particularly nociceptive pain in renal failure, I have in my mind safe things, the medications that are metabolized largely by the liver. That's paracetamol, and then our opiates of fentanyl and methadone. Fentanyl is a straightforward opiate, very quickly metabolized, though it does come with administration challenges, knowing we're limited to intranasal or buccal, patch, or subcutaneous or IV administration. Methadone, it has a very long half-life, often needing some very close monitoring and left to the specialists, and though a very effective analgesic. I've got the medications to avoid, as I've said, non-steroidals, though there's a question mark here. If someone has no kidney function left, what are we trying to preserve? And so for someone on hemodialysis with no residual kidney function, perhaps we could consider non-steroidal medications. So that would be in conjunction with the renal physician and making sure we're not, so we don't want to be doing any harm. Weak opiates such as codeine or tramadol have complex metabolism, and this metabolite buildup would be very concerning in renal disease. And here at the bottom, I've got oxycodone and morphine as maybes. The thing here really is to accept that they do require renal function for their metabolism, and particularly it's the active metabolites that can build up and have varying effects, resulting in toxicity, though they can also be extremely effective. And the take home there would be really understand how a person might respond if they can be under close supervision, and using half or quarter doses with longer time between administration, such as we'll talk about in our case later on. Simply put, I would say that we'd simply take the middle steps out of our analgesic ladder when we're dealing with someone with advanced chronic kidney disease. We know that pain isn't always purely nociceptive. There's a neuropathic component. Whenever a nerve is impinged, we would want to find the cause and the reason. Is there a mechanical or a non-pharmacological fix to their pain, such as carpal tunnel that might come from a lot of edema that a person with kidney disease has, or do they purely have a slip disc in their lumbar spine causing radiculopathy? You know that neuropathies come from diabetes and chemotherapy as well. So then excluding those mechanical causes, we then think of other topical treatments. Maybe menthol, lidocaine, or capsaicin would be useful. Very much person dependent, and then medications. I've put in this table and won't go through them all today. There's quite a lot of options. Remember, at end of life, um, uh, or simple symptoms, te ara whakapiri, or the end of life pathway from the Ministry of Health is is quite prescriptive and very safe dosing. And they recommend fentanyl for anyone with a estimated GFR less than 30 mils per minute. And like I say, safe and conservative there. Breathlessness, particularly troubling in renal disease, and often, particularly with comorbid heart failure, that is so common combination. Like this non-pharmacological, I think a model of breathlessness up in the top right corner here, remembering that breathing technique, breathing reasons and inefficiencies. If we understand how our breathing pattern is, then there's the thoughts or anxiety that can evolve out of breathlessness. And then there's the limitations on functioning. If we keep that in mind, it's often useful to talk people through so that they're educated and understand where their breathlessness is coming from, and provide them with techniques to, without the need for medication, be able to address their breathlessness in the moment. However, invariably people will need some support from medications. I would say addressing edema is really, really important in that CKD and heart failure, and that's where the role of dialysis and or diuretics come in. We know that diuretics work less well in the kidneys that are impaired. There can be novel ways of making sure that people are receiving those. We have had patients under hospice who have received diuretics subcutaneously to ensure that they get an adequate dose, and being able to keep them at home rather than landing in hospital each time for IV diuretics. Other medications, opiates, have good evidence for reducing the sensation of breathlessness. Morphine has the most evidence. However, we know our limitations in kidney disease, so fentanyl or oxycodone might be more commonly used. Note benzodiazepine, particularly good for the anxiety that may be associated with breathlessness. Just remembering that benzodiazepines have slowed or delayed metabolism, so we need to make sure our dosing starts low and goes very slowly. And oxygen is always suggested if a person is hypoxic, but I think it's very important to understand they need to understand how they feel with the oxygen over and above whatever changes to their hypoxia it results in. Restless leg syndrome, quite specific for CKD and quite commonly missed. Affects a quarter of people on long-term dialysis and impacts their sleep, fatigue, their mood. It's often associated with iron depletion, diabetes, or phosphate levels. The treatment is get the legs moving during the day. So whether that's sitting on, during the dialysis, sitting on pedals on the floor, just to keep the legs moving, stretching, reflexology, massage, and there's a plug there for our hospice having complementary therapists. I think that would have a great role in this setting. From a medical point of view, ensuring there have been iron supplementation, if the diabetes is being optimized, and then making sure that And then we can consider medications such as ropinirole, or basically dopamine agonists. Anorexia and nausea is also, related to metabolic end product, and acid buildup. Would make anyone feel nauseous over time. Not to mention how many medications that renal failure patients end up taking. In between, your appetite might be lost anyway if you're trying to follow. By the time you've spent all your energy trying to follow a low potassium, low phosphate, diabetic, and high protein diet. So that's really important to acknowledge, and important for us to remember that the renal service has dietitians who are experts in supporting that, and supporting the knowledge for people and educating around that. And then I suppose in the palliative setting, understanding what is the priority here. Does the person just want to eat the food that tastes good, at the cost that it might be high salt, and therefore they end up with a little bit of extra fluid retention? The other, when it comes to trying to reduce nausea or trying to improve anorexia, again, checking about dialysis adequacy. We want to make sure someone's mood is stable, they're not depressed, that's causing them to feel general nausea or persistently. And then if we were going to treat nausea, our standard medications are all safe, remembering start with lower doses. And I would always be checking the St. George's or handbook, or whatever formulary you particularly like. Insomnia, again, we've got so many multifactorial symptoms here, and this is a particular one that is a result of maybe a result of multiple other symptoms. So, have we found are all our other symptoms controlled well enough? Are they impacting at night? What could we put in place? And find it very easy to forget, but so important are these general measures. Again, exercise popping up, checking about caffeine, alcohol, smoking, these simple things that can often be overlooked, particularly amongst, I'm talking from coming through the hospital system, particularly in secondary care, we often overlook these things. Mental health is a huge component here, again, often overlooked. The statistic here of 1 in 5 or people receiving dialysis will have an episode of major depression, and less than a quarter of those people will have received any treatment, and that's for a number of reasons, both clinician and patient barriers. However, it's really important to acknowledge and make sure that we're, from the clinician side, that we're always checking and trying to support as best we can. We know that any mental health condition may cluster with uncontrolled or poorly controlled physical symptoms. But yeah, it needs its own specific treatment, and just general treatment support. There is exercise has got good evidence, cognitive behavioral therapy, and yeah, we're lucky here in the hospice to have the support of counsellors who may be able to engage patients experiencing mental health, particularly depression. And then if we are pushed, first line treatments are SSRIs, and they are well metabolized, and they're usually high protein bound and controlled by the liver, so they're quite safe in renal disease. Don't forget about anxiety and post-traumatic stress, and definitely do not forget about the support people around the patient. It's not just the patient living with end-stage renal failure. Their support people are often very stretched. Um, Cognitive decline is a major thing, and this, for me, comes from is very important to remember and acknowledge when I'm meeting someone for the first time that this is something that will be progressive. It can come from their cerebrovascular disease. It's associated with the process of kidney disease, dialysis. There's a lot of fluctuations in pH metabolites, and it doesn't filter everything that might be a culprit of causing cognitive decline. The fact that cognitive decline is a progressive thing just absolutely highlights that early and early advanced planning and advanced care discussions and establishing EPOAs is extremely important, so that someone that when things do change and totally impact function, that we can that a person's wishes are going to be able to may have a better idea of what they want. If they can't then be saying it. And the multifactorial nature and impacting and the multifactorial fixed symptom is fatigue. Um, every organ implicated by when the kidneys are working less well will all interact in a way that is often seems nebulous, but I like this diagram on the right that it reminds me to address that I need to be addressing each component to try and help somebody's fatigue overall. And that's really taking control of, again, exercise. What can I do to help a person's mood? Is it a medication? Is it counseling? Is it CBT? Is it improving their sleep? Nutrition and making is another. These are all things that we could modulate or address in the goal of helping us reduce a person's fatigue. And now I'd like to just change so that with so many symptoms, it's yeah, no surprise that palliative team wants to get involved and provide that holistic, comprehensive, and goal-focused care in a sense of this life-threatening disease. And remembering that palliative medicine is done in primary care, it was done by the renal team, it is done by GPs, it is done by the emergency department, but then there's also the specialist services, of which hospice is considered. I think here are the just trying to highlight the renal team's focus is making sure that a person's kidneys are working as well as possible in the circumstance, their dialysis working as well as possible, and that becomes a lot of medical, and that gets very medicalized. And given how complex it can be, a person's living with the disease, their priorities may be missed or they might misinterpret things. And so I think a palliative focus is making sure, and I see the palliative team and the palliative focus being this arrow here, this liaison, making sure that the person understands what the renal team is doing and what the reason for their treatments are, and making sure that the renal team and the clinicians involved understand what the patient's priorities are. So I see liaison as a major liaison and understanding as a major component, and throughout, obviously, always acknowledging the complexities of renal disease and what its care needs. And now but do you think people can live for years with on dialysis, live for years with chronic kidney disease? When should palliative care or this palliative approach be introduced? As early as possible, in my opinion, though largely, uh, and that may be primary palliative care to start with, before specialist needs arise later in the disease course. I think overall we can see that chronic kidney disease follows the trajectory two, or this yellow line of organ failure, with a gradual decline uh, with events that result in some acute drop in function that returns to a new baseline with a continued decline. However, many renal people with renal disease might, particularly if they're well controlled on dialysis or with a renal transplant, may follow trajectory one, where things tick along beautifully for a long time until a single acute event puts them into end of life. Similarly, renal patient may have frailty as well. So there could be a whole combination of these trajectories, and that makes it quite a challenge. In my search to understand what trajectory patients follow, I did come across this cohort study from the UK, which measured a renal patient's performance scale in their last year of life, um, and found that actually many will tick along quite beautifully about 6 months out, have a slight dip, but particularly the last 2 months of their life had a was a dramatic, rapid drop in their function. And these people in the last year of life, if we have a KPS, to put some context, a KPS of 70 is a person that's able to care for their own needs, but unable to perform normal work. So they're in their home perfectly well, but they're not fit enough to get to work, or but then level 60 is that they've just started to require some occasional assistance. And I'll acknowledge that that's a very broad category, and many people. So to try and be a bit more specific about when to get involved with palliative care, I quite like the SPICT tool. Clinicians or people always have a sense of the surprised question. Have then And these would be reasons to consider referral to palliative care or introduction of the palliative approach with their patient. So yeah, would you be surprised if your patient died within the next 12 months? Other reasons, have you noticed a functional or cognitive decline? If their frailty built up, or if they had repeated unplanned admissions to to hospital. If a person's on dialysis, are they tolerating the dialysis more worse? Are they considering changing from hemodialysis to peritoneal dialysis because of the strain on their body? Are they considering withdrawing from dialysis? These are all reasons to get palliative, to introduce palliative support. Particularly important, I think, is and then understanding if anybody has inadequately controlled or escalating symptoms or comorbidities, such that their life is significantly limited. And that's by comorbidities, I mean the other things in their life aside from the kidney disease. Is their heart starting to fail? Is their cognition completely gone? Are they not able to have cancer treatment because their kidney function is so poor? These are all reasons to have a palliative approach introduced. I would say, so yeah, this trajectory of functional status just sort of suggests if somebody's function is declining, they should be considered for a palliative approach. And similarly, that same study found that a person's symptoms escalated quite rapidly in the last 2 to 3 months of their life, which highlights another reason that yeah, if symptoms are poorly controlled, then palliative approach is important to consider. If there's any doubt, if there's any sense, there's always specialist services that we're happy to hear from anyone. And yeah, we have our doctor's direct line, and hospice is available all the time for advice. This brings me to our case of Mr. D. who I think will just be great to get our panel involved in the next few minutes. Mr. D was a 70-year-old man with end-stage renal failure. He'd had a long history of hypertension and had mild or CKD3 um, since 2013 for 10 years. In 2023, things had just gradually progressed, and he was planning peritoneal dialysis. His other comorbidities, ischemic heart disease, and a prostate cancer that was um, very slow moving but had spread locally. And on the right here, I have just his creatinine level over time. So that's his actual kidney function tests. And I mean, the normal level would be uh, at around maybe a centimeter, sorry, about halfway up this first box. So he's about three times or a third of normal kidney function. He wanted to keep working. He's a very hands-on man, active. He wanted to keep doing his project cars, and he wanted to remain independent and out of hospital. This was all in the peritoneal dialysis planning clinic. That's why he chose peritoneal dialysis that he could do in his own home over hemodialysis, which would take him into hospital three times a week. His symptoms persistently throughout this time was fatigue, dyspnea, edema, and low mood, and he was on multiple different medications to try and control that. His anemia was being controlled with injections. His heart failure was on a lot of diuretics and varying antihypertensives, etc. He had depression and was on paroxetine also. However, in December, there was a sudden change. He developed acute urinary retention and an acute kidney injury that landed him in hospital. The urinary retention or hydronephrosis was resolved. However, his kidney function remained poor, and he had to acutely start hemodialysis. What you can see that big drop in the kidney and the creatinine level. Unfortunately, he, after a few weeks, had a cardiac arrest during one of his dialysis sessions. He was revived and stabilized on the renal ward, but his cardiac status meant that he was no longer fit for hemodialysis, nor could he have be put on peritoneal dialysis. So he was referred to hospice for support. Here we have an important question of another poll of what is our life expectancy on withdrawal from dialysis? Is it 1 to 3 days, 1 week, 4 to 10 days, approximately 2 to 3 weeks, 1 month, or 2 to 3 months? And I suppose the best would be what is the most likely life expectancy for a person stopping dialysis? Understanding we know in medicine there's always a range, there's always some uncertainty. Great. So I hope we all have a range, and I see that range may fit the bell curve. And 4 to 10 days and 2 to 3 weeks is the majority, and that was where most people will die. And I absolutely acknowledge, and we might expect that some people live a lot longer. And that's also what the statistics show, that the mean or the mean survival from the last dialysis treatment, whether that is that from when a patient stops dialysis is 7 to 10 days that they would live. There's I'm quoting it into a recent Australasian study that looked at dialysis withdrawal between 2018 and 2022, and they found the median was 7 days, with 50% of people dying between 2 and 11 days. But there were some people that lived more than 100 days. Um, you were more likely to live longer if you had a residual urine output at the time you're stopping dialysis, or if it was a patient-driven decision for a psychological or a social reason, you were likely to die in a shorter time if it was an acute cardiac event or a neurological event that resulted in you removing dialysis. So we have this uncertainty for our man, Mr. D, and we actually found that for him, he on referral to hospice, were able to get some advanced planning done very early, and his wishes to remain at home. He really wanted to go for a drive and work on his cars, and though he was quite shut off, particularly depressed and reluctant to talk about much more, but was very trusting that his family was able to know, would be involved in discussions and know detailed investigation information. It was progressive. He had physical symptoms of progressive edema. He had persistent chest pains. GTN lost its effect quite quickly. Oxycodone he found very sedating, and he was on 2.5 milligrams every 6 hours, but that was too much. Fentanyl intranasal provided a minor relief, but there needed to be a subcutaneous route. He did develop a delirium with particularly bad overnight with insomnia. Haloperidol initially was then changed to levomethomazine. He had progressive gradual functional decline, both physically and cognitively, as the family were contemplating struggling a lot to keep him at home. They were contemplating atrial player placement. They eventually died before that happened, and he lived 4 months from his last dialysis. So he was a very challenging patient, and I'd now like to, and there's so many aspects to his treatment, and I'd like really to hand over or introduce Charlotte George, one of our clinical nurse specialists in palliative care, who had and share her experience working with Mr. D.
Thank you. I think Mr. D was quite a challenging case in that normally, like you said in your slides, people come to us after a decision's been made, sort of together with the renal physicians, about stopping dialysis. He didn't really have that opportunity. The difficulty with this cardiac arrest and the sort of overall feeling from the family was that this was caused by, he'd gone into hospital and he contracted COVID and pneumonia, and that's sort of what precipitated all of that awful cardiac arrest and the decline following that. So those sort of decisions had got taken out of their hands. And like you said in the slides about sort of PTSD and anxiety, that really did sit with him, and more so with his wife. I think she really struggled with regretting taking him to hospital and feeling like that was the sort of precursor event to his decline. And she struggled with not sort of pursuing maybe him being able to have dialysis, down another route, accessing further advice. Like you said, he was very, very depressed. He had a love of cars. His driveway was full of cars that he had worked on through his life. And really, for those 4 months after that decision was made, he sort of sat and looked at those cars, but was never really able to get back out to them. We tried a multitude of antidepressants alongside the help of his GP that really didn't make much difference for him. And I think that was really hard for him and also for his family to see. He had been this, very vibrant and active man in his life, and now really was just sort of a shell of himself physically and emotionally. Um, there was a lot of stress, in the family trying to manage this. And the 4 months, actually, he did sort of follow that pattern of being on sort of a line of being quite stable. And you sort of get into this phase of, this is sort of normal life. And then he suddenly started to decline. And that was also exacerbated by his heart failure. So he had his ischemic heart disease, then, and obviously the result of this cardiac arrest as well. So he was very symptomatic. And I think on reflection, I don't think I've met a renal patient who's probably ticked all of the symptom boxes like he has. Overnight, blisters would just pop up on his hands and his feet, which were incredibly painful, which would then burst, which would then need dressing. He had quite a lot of peripheral vascular disease, so a lot of issues with painful feet, purple feet, cold feet, that exacerbated things. And it was very difficult, I think, for his wife, who was his main carer, to try and ascertain what was effective for him in terms of symptom management, because he was so flat in when he sort of was asked, how do you feel, or how did that help? Yeah, it was a very difficult situation, and they managed incredibly well with his care and at the end of his life. And although they had made the decision to go to aged residential care, he did die at home. Actually, the day before that was due to happen, and I think that was an incredibly good outcome for everyone involved. And I think that we've all learned from his situation to be able to care for future renal patients.
Yeah, absolutely. Such a um, complex case, wasn't it? And on so many levels. And I really think, well, in my few times meeting him, that absolutely that space that we have in their home to be able to acknowledge and just be with and as a support, acknowledging the complexity and the difficulty of the challenges that he was facing, even if we didn't have a uh, amazing silver bullet fix for his case. That issue also makes me, I think, uh, would like to move to talk to Patricia, our hospice West Auckland social worker, around the benefits or the utility of advanced care planning in such complex people. Thanks,
Yeah,
Patricia.
thanks, James. You you did allude earlier to in a slide about the fact that yeah, ACP advanced care planning sits alongside EPOA, it sits alongside wills as well, and I think this is the important thing. When you're trying to initiate a conversation with people about advanced care planning, it's saying, well, we need to get all your ducks in a row so you can get on with other things that are important to you. I looked up a few studies about advanced care planning with chronic kidney disease and families, and if you're interested in this topic, this particular study talks about advanced care planning. The aim of it is about giving the patient and their family the opportunity to be supported, to share A, what are their values, B, what are their preferences, and C, their wishes for treatment and for the family and everyday life, living with this illness and the treatment that is going to be involved. So it is a conversation. It starts hopefully early on, as with Mr. D. One of my colleagues started that the ACP conversation. So we need to find out who the family is, and this is where drawing an eco map is quite good. Who are the family that are around this patient, and then who are the other resources that are going to support this patient and their family? Is it just Mr. D with his issues? Are there other members of the family that are having their own issues as well? Because we know that's often the situation too. And to make it a strong conversation that's about what what have we got here, and what are the important things that the family can offer, and how are we going to go forward. And it's about, okay, we start the conversation, but when we meet this patient and their family again, we review it. We look at, okay, where are we now? What else do we have to do to support this person? And I think in terms of being able to do an advanced care plan, if you've done your own, if you've sat in that patient's shoes and thought, if this were me, what would this look like? Then I think you've got a good basis for starting a conversation with somebody else, because you've kind of understood what it is. But I think, yes, starting early and continuing the conversation and involving all the people who are part of it.
Absolutely. I think there's, yeah, and I would also wonder about remaining open to a person's change, that they can change over time. I think one thing for Mr. D particularly that sat with me was his absolute expression of wish to remain at home in the early, well, throughout while he was engaging. But at that same time, he also acknowledged that if it was more important for his family to need to do something against what he'd written down, or what he'd expressed, if they needed to do that for them and them, well, he was open, he was allowing that to happen too, and that was where that. Yeah, well, they were in that planning to move to aged residential care so that they didn't fall apart as well. It's the whole picture. Yeah.
And I don't think it hurts sometimes if, like Mr. D, had a bit of a sense of humour, and I think it does help to to make a conversation light as well. It's not all heavy going, and that certainly helps normalise this process and accept the change that's happening for this person and their whānau.
Yeah, that's great. Thanks so much, Patricia, and thanks all. We're running, well, time is running quickly ahead, and so I would really just finish up here. Apologies, not as much time for question and answers as may have hoped. But yeah, I mean, my take-home messages would be really that remembering in kidney disease, its symptoms are prevalent, multiple, multifactorial, and can come from multiple different sources, and interact with each other. Our renal metabolism means we need to go slow, start low and go slow with our medication, our prescribing, and then the role and overall good symptom management is going to require support from multiple different sources. A lot is going to be held by the renal team, but primary care, palliative care services need to be acting in that liaison role, aiding understanding and providing that full wraparound, and to make sure we're understanding what the patient's priorities are, and thinking ahead. Like I said, I would suggest, and also, yeah, remember that there's a lot of specialist palliative care service available here in Hospice West Auckland, and those are our contact numbers. Before I finish off, would there will be an evaluation of the webinar for any. So please, any comments or any suggestions for future webinars would be much appreciated. And to close off, I'll share our Hospice West Auckland karakia and wish you all a happy day. Turuki whakataha, haumie huie, taiki.